Alrighty, so let's do
Article
Article 4,
4.
and we're still sort of on the musculoskeletal stuff, and now we're going to look specifically at how often is MRSA in the organism in adult septic arthritis. And this is by Brad Frazee up at Highland and some colleagues, so hi to them up in Northern California. And this is not huge numbers. It's, this is a relatively small paper, but it's not stuff that's been dealt with, and it's an emerging topic, so it's worth following along. So septic arthritis, as we know, medical emergency, going to destroy a joint. You're going to make someone into a cripple. Delay in diagnosis can lead to that problem, so you don't want to miss it. Clinical exam is fairly unreliable, and diagnostic arthrocentesis is usually necessary. The results of that arthrocentesis can take a while to come to you as well. Fluid culture is the diagnostic criterion standard. Again, that's going to take 2 days, 4 days, a week to grow out.
Right, doesn't help you now.
And the decision to treat is based on the overall clinical picture combined with the synovial fluid analysis. Staph aureus is a common pathogen, but what's not known is how common is an MRSA. And so this group of authors...
MRSA. Is MRSA in there now too?
So that's the question, and they're going to go ahead and take a look at it. And the study addresses this proportion. It's a cross-sectional retrospective. It's not huge. It includes adult patients, only adults, having an ED arthrocentesis where there was culture. They eliminated the contaminants, not so helpful for us, but it would be nice to know how many of them there were, but there you go. And then they reviewed charts with all of the limitations that come with that, with a chart review, to determine the presenting features in patients who are MRSA positive. So those features might not be so great because it's a retrospective review, but at least the standard that they grew out MRSA is a good one, so it gives us some idea of what the numbers are and how frequently we're going to run into it. So 109 fluid cultures were reviewed. 23 grew organisms. That means a lot of them were sterile, which we know is often the case.
You'd expect it to be.
Often the case. 9 were contaminants, that leaves 14 real infections, of which 12 were from joints. And 10 of those 12 were staph, so some were salmonella, maybe in a sickler, or things like that. So 10 were staph. And of those 10 that were staph, 6 were MRSA. Hello, we're there. So the MRSA has moved into the joint along with the
not surprising.
Any habitat that's good for MSSA has so far yielded itself to be pretty good for MRSA. So if you look at this, this means that MRSA caused about 50% of the cases of septic arthritis among those that were truly in the joint. And so there you go.
Right, in a small study, but that's still half.
It's still half. So, you could do the sort of sensitivity analysis or look at the confidence intervals, and they'd be hugely broad. But obviously, this is a hard thing to do. You got to pull up all the cultures and do it. But anyway, so I still think it's informative. The demographics of the 12 septic arthritis cases, so no prosthetic joints, though they have an even higher rate of staph. 6 occurred in injection drug users. Not surprising. We see a lot of that. 2 patients were febrile triage. Of those, both of them were MRSA positive. So this means that, again, just like in the last section, fever is not the be-all and end-all. Now, this is sort of interesting, and, this I don't know if it's due to the small sample size or
this
what.
One I'd like a big study to see.
But I'd like a bigger study, but there's interesting supposals that you can make, sort of suppositions. So the mean synovial count for white cells with MRSA was 15,000 versus 85,000 for MSSA. So you might say, what that mean? And possible things you might think is because of the Panton, Valentine, leukocidin sort of aggressive necrotizing features of this, they might hurt more and they might present earlier. It's the same reason they call this a spider bite, because they've had skin infections before, but they didn't hurt that much. And that PVL is really the responsible content for that. So maybe that's part of it. The other thing you might think is maybe it's more aggressive or they felt worse and so they presented earlier. All purely supposition. The numbers are too small, but I don't find it that out of whack with what I think about this.
No, and if this were to prove to be true in a bigger study, that does make our job significantly more challenging.
I agree. And so then they go to, because you'll hear people regularly turn away. That can't be a septic. That cell count's too low. Au contraire, mon frère. Now, they did the susceptibilities, and of course we want to know that. Is there going to be something new to find here? Generally speaking, no. All 6 were susceptible to TMP sulfa, Vanco, and Doxy. 5 were susceptible to Clinda, but remember, Clinda is often inducible in these, so it might not be a great choice, particularly for an infection that you got to treat for a long time. right? Because the Clinda inducibility can happen during the course of a single treatment. The longer that treatment is,
Right, more likely.
either you're going to have cure or you're going to induce. And 4 was susceptible to levo. So that's pretty similar to what we're seeing, and it sort of underlines sort of the basic things that we know about community-acquired MRSA, which is it's nasty, yes, it makes the PVL, it's invasive and it hurts. And 2, it's not that nasty in terms of its resistance patterns. Hospital-acquired MRSA has much worse resistance patterns, generally speaking, than community-acquired
It's unfortunate
MRSA.
that resistant is in its name.
Yeah.
Because it does give this sort of false feeling that it must be something terrible. It dies with a lot of different
And
antibiotics.
and it is true also that methicillin resistant means it's oxacillin resistant. So there are a couple there, but still, this means that we're not. It's not like you're reaching for the cubicin just yet. Sorry to those manufacturers and sellers of the cubicin. So in the discussion, according to traditional teaching, Staph aureus, up to 50% of adult septic arthritis, usually hematogenous spread, so the IV drug abusers are in there. It's MRSA's incidence has been increasing dramatically over a wide array of soft tissue infections. In this case, they found that MRSA was 50% of their adult septic arthritis. So it's there too, is basically the bottom line. Authors suggest that if you're going to treat a pyarthrosis, you better cover it. I think that's reasonable. I certainly would. Vanco's a reasonable first choice if they're coming in for IV antibiotics. Don't hang your hat on the white count, either in their serum or in the
tap.
Or in the tap. Suggests a low threshold for antibiotics and admission until culture results are available, because if someone ends up crippled, and these often don't have great outcomes, some of them actually even need to go to the OR and get washed out at some point. Although that's being done more selectively now.
Yeah.
It used to be that every
Everybody
single
got
one
it.
went. Now they're doing them more selectively. But still, you want to be on the upside of this, not on
and
the
I think the
minimizing
Vanco
side.
suggestion is a good one.
Yeah.
You can always, once you get your susceptibilities back, change to something
Right.
more specific.
So
And
we've
if it turns
always
out to
been
be
told-
MSSA,
right.
you can switch it. But
So we're always told to reserve the Vanco, but you can't reserve it if it's half of them. You ought to launch. So, MRSA may, which means, as just in honor of Jerry Hoffman, let me just say what he would say. It also means may not account for up to 50% of cases of adult septic arthritis. Synovial white counts in this small series were deceptively low. I don't know if that's true. I can think of reasons why it might be true, but I'd like to see better numbers. And you should have a low threshold to cover MRSA given the results of this
I think they chose
small
this
group.
paper just to bring to mind that MRSA is no longer just in the skin. We know it can get into the lungs of people that
Yep.
have
Post-viral
infection. It may be MRSA instead of MSSA, and now it can also get into your
I
joints.
think they chose this article for a bunch of reasons. It's relevant for us.
It is.
We have to deal with consultants on this. It was a paper done by us. And so, no, I think there's other reasons for this to be chosen. And it's relatively new. It's evolving. There's no other paper that deals specifically with this issue that
we
I'm
spent
aware
a lot
of.
of MRSA sort of time on LLSA
Yeah, yeah.
articles in the last years. This is now a new area.
All right.